on to our next speaker, who we're thrilled to have, and that's Dr. Radhika TANDON, who's going to be talking on the genetics of corneal dystrophies. This is a very important talk, so I'm glad that you're here.
Thank you so much, Jerry, for inviting me to participate in this instruction course. And genetics of corneal dystrophies, keeping in mind the theme about the current methods of genetic analysis and potential genetic treatments, I've tailored the talk according to that. And basically, the advances in ocular research, it's another frontier that has opened up: molecular genetics, epidemiological studies. And then when you go for interventional studies, you can have a holistic approach, a multidisciplinary approach, and also personalized medicine. And as you've seen before, the molecular genetics is giving you that platform that you can aspire to in future to give precision and personalized medicine. However, this is not very easy to do. There are a lot of funding initiatives that one has to generate. There are several platforms. In India, we have the DPT, DST, ICMR, CSIR, to name a few. And generally, with all research proposals, for some of the new people here, of course, you're already tuned to all this, that you have ethics, one can consider conflict of interest, finances. All of this also has to be taken care of by a PI. And people who are going to progress to be their PIs, themselves independently run a research project, it's important not only to do your project work, but also see how your superior, your head, your PI is managing things, and try to help in those protocols, because you are the future. By the time all this is going to translate into an actual event for a patient, it's going to be several decades for most diseases. So therefore, we're looking forward to the young ophthalmologists today to be interested in research and to take this forward. Now, what about cornea services and how are we placed in India? Now, we do have our unique populations, and a little perspective about how there's been a sea change and how one looks at corneal dystrophies. Originally, it was a very anatomically oriented classification system, but this has now been updated. It was initially proposed in 2008, then updated in 2014 and 15, and again further now it has been defined in 2024. So updated classification, what drove this change? The key change was genetics. It was only when the genetic information came through, it was clear that you can have the same gene and have different manifestations. Different diseases of the cornea could be affected by the same gene. And similarly, the people with the same gene can even have varied manifestations. So that was very confusing, and ultimately it is the genetic makeup which actually classifies the dystrophy and gives it its place. So there are various categories. As you can see, that there are some where one has not reached that level of having a very clear-cut identified locus and gene, and the ones which are doubtful have now been removed from the list. So I'd encourage you to please look up IC3DC. It's available open access through the Cornea Journal. And now, what implication does it have for India and Southeast Asia? So we have obviously our own problems, our own niche areas where we need to focus our energy. And we held this kind of a think tank workshop several years ago to try to identify that if we were to apply for funding together, what diseases should we work on? And that time we collectively decided that it would be retinitis pigmentosa and CHED. CHED is congenital hereditary endothelial dystrophy. So there was a lot of discussion, a lot of back and forth, and there was not only a question of what is important, but also what is doable, feasible, and what would make a sea change. And the idea is that one should have a consortium of organizations which are working for the study of the genetics of ophthalmic disorders in India. And then, of course, there was the Asian Eye Genetics Consortium, which was created. So a little perspective about now, a lot of work has been done on corneal dystrophies. I mean, a lot of publications from South India, but there was less information from the north of India. And we know that the corneal dystrophies have varying features. So we had wanted to screen our patients to see if it is mirroring the reported information from other parts, or is it unique? And there were certain unique features that came across. Basically, the distribution was a little bit different. The autosomal dominant, the were certain new mutations which were identified. All this information is published. So if you look up Paliwal, R. Tandon, and corneal dystrophies, you will get the publications to go through. And then so I'm just trying to show you in a snapshot that how the work was done and how one found novel changes. One found that there could be variations in clinical presentations. This was a novel mutation seen in granular corneal dystrophy, for example, another novel mutation seen with Reese-Buckler corneal dystrophy and Avellino corneal dystrophy. If we hadn't started this journey, this would have been left and would never have come to the notice of the scientific community. So therefore, there is an encouragement that one should continue doing research and find the ways to get through the hurdles. Here again, there was another variation with lattice corneal dystrophy, a new mutation, another one in MAP-dot fingerprint dystrophy. And now the question is that does it help you in your clinical care? It definitely does, because now that we know what are the patterns, we are trying to get the routine screening for all the patients, plus we are able to have a good database and a good atlas of what the clinical pattern looks like. And of course, the holy grail is to have a very good correlation between the clinical picture and what is the likely gene. However, that is a little complicated because often you have patients in different stages of the disease who may come, and also their disease pattern may be complicated by different things like environmental factors and other things such as UV exposure. They may be associated pterygium, or they may be associated spheroidal degeneration of the cornea, and so on. So similarly for endothelial dystrophies, again, we have looked at our CHED cases. We had more males than females. 39% only were familial, and we had also looked at Fuchs and posterior polymorphous corneal dystrophy. And a certain new features we found because we've actually had patients of CHED who even 30 or 35 years old. That is simply because of the lifestyle of the patients. They were able to manage with that poor vision for so many years, which is unheard of normally. Like normally would expect the patient to present within 1 year of birth, and in fact at birth. So the way our country has progressed over years, of course now it's rarer and rarer to get patients presenting so late, but still it gave you an opportunity to see what is the natural cause of the disease. So you can see there was a Hudson-Starley line, there was spheroidal degeneration, and so on. In Fuchs endothelial dystrophy, again, there's scarring, Bully, and Desmond's folds. Most of these are very common changes which are seen internationally and elsewhere as well. And then we looked at, in CHED, the SLC4A11 gene, and out of 35 patients, what is intriguing to me is that though the patients were very characteristic, and there was no doubt that it was CHED, but we were able to find the mutation only about 39% of cases. So this is again work in progress as to what could be the reason for that. And it has a relatively lower occurrence in North India. The pattern of consanguinity seen in North is among cousins rather than between the uncle and the niece. Maybe, I'm not sure whether that makes a difference. And a high degree of consanguinity was seen among the patients of CHED. So no mutation was identified in 21 patients. They were screened. So what did we do with them? We screened for putative promoter. Again, no mutation. Screened for COL882 gene, whether it was there was a theory sometime earlier that maybe patients with Fuchs, some of their other relatives may have CHED, maybe it's a early onset, but that was not the case at all. There were very, very clear-cut clinical cases of CHED, and there could be existence of genetic heterogeneity, overlapping cases, and definitely lots more work to be done. A quick word about the molecular analysis for Fuchs dystrophy, COL882 gene. That is also something that we have worked on, and I'd like to acknowledge the Department of Biotechnology, Department of Molecular Genetics, led by Arundhati Sharma, the cornea services, all the clinical faculty, the ocular pathology, and the Department of Anatomy. So as I said, you look up Paliwal, Arundhati Sharma, Radhika, Tandon et al., and you will get most of the publications if you're interested. Thank you so much.